In Module 1 and 2, we learned about basic immunology and the body's response to allergies and immunotherapy. The first two sections were designed to be non-proprietary and generalized so that you can claim CME credit for completing them. In this module, we'll see how the Allergy 1-2-3 program has perfected the immunotherapy process and made it simple for primary care physicians to incorporate into their practice. This isn't rocket science, and any primary care doctor can do this program and feel confident in their ability to test, diagnose, and treat allergic or asthma patients, including immunotherapy, with a high degree of patient satisfaction and minimal risks. I'm going to try to give you all the tools you need to run a successful allergy practice, which is easily integrated with your primary care practice. As a practicing physician with over 20 years of experience in family medicine, I know how hectic your schedule is and how hard it is to make major changes to your office routine. So we've tried to make this integration as simple as possible. I've outlined the subjects I feel are the most important for you to understand. Our allergy nurses are thoroughly trained to help you with any clinical decisions, but it's important for you to understand that they work incident to you, which means they are your employees for the day, and all clinical decisions are ultimately up to you. We're going to be talking about how to make a proper diagnosis to qualify for insurance billing, skin testing and interpreting skin test results, choosing the most relevant allergens, immunotherapy dosing, as well as safety and liability considerations. Then we'll talk about home-based immunotherapy and sublingual immunotherapy. Insurance billing and reimbursement is important for you to understand, but we'll also be working with your billing staff to teach them everything they need to know. Let's start with diagnosing allergic rhinitis or asthma. You all have been doing this on a daily basis, and I don't need to tell you how to diagnose allergies, but I would like you to be more aware of the impact of allergies because your patients often don't even discuss it with you. They may think that everyone has allergies, and remember that 20 to 30% of them do. And they may think that they just need to live with it and take over-the-counter antihistamines. Here are some common diagnoses we see every day, which might lead you to consider allergy testing and treatment. I keep a stack of these forms in my exam rooms to complete if a patient seems to be a candidate for testing. For example, if they're in for an unrelated problem, but I see that they're using Flonase or Zyrtec, or have had numerous sinus infections. I just circle a diagnosis, sign the form, and tell the patient to schedule an allergy test on their way out of the office. I've been in private practice for a long time, and I know how busy you all are, but it only takes a few extra minutes to ask a few extra questions, which could make a huge impact on the patient's quality of life and result in reimbursement equivalent to about 10 or 15 office visits. Notice the questions highlighted in red. My receptionist will typically ask the patient these questions. If they're all negative, she will schedule an allergy test for the next available allergy clinic day. If any are positive, testing needs to be postponed. Disqualifying questions include recent steroid use, beta blocker meds, or pregnancy. The remainder of this form is usually completed by the allergy nurse at their testing appointment. We already went over how a typical allergy test is done in the last section. We usually test the patients on their arms rather than the back, and have found that it's much more comfortable. The patients are fascinated to see how they react to each antigen. Here's a picture of the Comfort 10 lancets we use. They test for 10 different antigens at a time and have tiny steel lancets which barely break the skin. Many allergists use a plastic lancet that needs to be ground into the patient's skin and is much more uncomfortable. The test takes about 15 minutes to perform, and a determination can be made immediately whether the patient qualifies for immunotherapy or not. For the allergy shots, we use a 1/2 milliliter syringe with a 31 gauge needle. Every patient I have had who is reluctant to give themselves a shot has been amazed at how virtually painless the shots are. I keep one of these allergy syringes in my exam rooms to show to the patient. I was even able to convince a 7-year-old who is deathly afraid of shots to try it. We test for the 58 most common allergens in a geographic area. The allergens are grouped into 20 trees, 10 grasses, 10 weeds, and 18 molds in animals. The last two are the histamine positive control and the saline negative control. If the histamine control is negative, the test is invalid because the patient is anergic or has taken an antihistamine. If the saline control is positive, the test is invalid because the patient has dermatographism or highly sensitive skin. The allergy nurse will write in the millimeter skin reaction next to each antigen. The different colors indicate allergens with similar proteins and cross-reactivity. The numbers immediately following some antigens that are in color are there to indicate which plants cross-react with each other if you're working off a black and white copy. Notice the 7s after all of the green grasses. The next numbers indicate which months it pollinates, and the A, B, or C indicates the relative degree of pollination. For example, an A pollinator produces lots of pollen, and a C pollinator may be insect pollinated, or in the case of pine, have large pollen grains which are poorly aerosolized and don't travel far. If the patient elects to pursue immunotherapy, he signs the form indicating he wishes to have us mix up their entire course of immunotherapy, and the doctor's signature serves as a prescription order. Our Allergy 123 mixing specialist or nurse will custom mix the antigens at your office to remain compliant with insurance regulations. Once a patient is determined to be a candidate for immunotherapy, this is how we choose the most appropriate antigens or allergens. Our protocol is to choose the 5 most reactive allergens, but you can choose less if indicated. Studies have shown that if you treat with more antigens, there's a higher chance of adverse reaction and less efficacy. Paying attention to cross-reactivities and the patient's history is very important to get the best combination of antigens. For example, say a patient is allergic to several trees but has symptoms only in the fall. You probably don't need to treat for trees and should choose more weeds or grasses, even if there's a stronger reaction to some trees. Another example, a patient is highly allergic to cats but has no intention of ever owning a cat, then why treat them for it? The Allergy 123 nurses are thoroughly trained to help you make this determination, and you'll get very comfortable doing this during your clinic in-service training. We don't combine molds or cockroach with any other allergens because they contain proteases which break down the other proteins. If you want to treat for both, they have to be mixed in different vials, and the patient needs to get 2 separate injections each time. One of the most important advances in recent years is the availability of standardized extracts. The FDA has standardized most of the commercially available allergens, so there's a known amount of allergen per unit. The BAU, or bioequivalent allergen unit, is a measure of each allergen's antigenicity. We mix the allergy serums with a pre-calculated BAU to achieve the highest degree of efficacy while minimizing the toxicity. We also use only glycerinated extracts, which are widely considered superior to aqueous or freeze-dried extracts. The allergy serum should always be kept refrigerated as the proteins quickly denature at higher temperatures. Here's another test results example. I've left the 0 reactions blank to see the positives better. As you can see, picking the top 5 most reactive tests is not easy at first glance. I think this is the fun part of immunotherapy, and this is where the patient's symptoms and the pollination characteristics come in useful. Let's say this patient has year-round symptoms. Their symptoms could be due to any or all of the positive results. Further questioning of the patient may say that their wintertime symptoms are just as bad or worse than spring or summer, and they have a cat or dog which seem to make them worse. This suggests that the mold and or animals are the primary culprits because the trees and grasses don't pollinate in the winter. On this patient, I would probably choose cat hair, cat pelt, both dogs, and DF mite. You could argue that you should pick the 3 molds and nothing else because, remember, you cannot mix molds with other antigens. But treating for molds is not usually as effective as the other antigens, and you'll get more bang for your buck by treating for pets. Another example. Say the patient has symptoms primarily in the spring and no symptoms in the winter. You can eliminate all of the molds in animals, unless he says his pets cause symptoms. Grasses are the major culprit, so I would pick one green grass plus bahia grass, sycamore, alder, and cottonwood. You might think willow instead of cottonwood, but willow is a C pollinator. Likewise, pine is a C pollinator, so I would pick alder and get a twofer for alder and birch. Bahia is a better choice than Johnson because Johnson is a bee pollinator. By the way, green trees are not cross-reactive with green grasses because each plant type, trees, grasses, and weeds, are treated separately, and there's only so many easily identified colors to choose from. One last example. Suppose a patient has summer and fall allergies and absolutely no symptoms in the spring. My first thought would be that we need not treat any trees, but look at the pollen calendar. Elm pollinates twice a year, spring and also August and September. In order of importance, I would pick Kentucky blue because it's the most prevalent of green grasses in most areas. Bahia grass, again you get a twofer for this one. Elm, careless pigweed, and ragweed. Ragweed's an A pollinator and also a twofer for cocklebur. You could also pick a second green grass to more effectively treat the grasses, but remember not to choose more than 3 in any one color group. Our allergy nurses are very helpful in helping you choose the best antigens, but you'll quickly become very adept at this as well. Our dosing schedule has been researched extensively and developed to minimize adverse effects. We have a slower build-up phase than most allergists use. This is not a race. It's okay to take longer to reach maintenance if it means there's less risk. We usually start with a 1 to 5,000 dilution, but if the patient has a reaction on his very first shot, we can dilute it further to 1 to 50,000. The patient gets a shot twice a week, but is advised not to do 2 shots on successive days. The dose is slowly increased over the next 6 weeks, at which time the patient is started on the next vial of 1 to 500. The titration continues until a final dose of 0.30 milliliters of a 1 to 5 dilution is reached. The ramp-up phase takes about 6 months, then the patient stays on the maintenance dose twice weekly for the remainder of the year. If at any time the patient has a large local reaction or a systemic reaction, the dose can be reduced and ramped up more slowly. Patients are encouraged to take an antihistamine and avoid allergen exposure on their shot days. After 1 full year of treatment, we schedule the patient for repeat skin testing and determine if it's appropriate to continue shots for an additional year. 2 years is usually recommended, even if the skin test shows complete resolution. This is because permanent immunity is unlikely until the patient has received another year of injections. Interestingly, on the retest at 1 year, many, if not most, of the allergens show a reduction in reaction, even if it's an antigen that was not chosen in the first place. Here's an example of a 6-week dosing schedule. The first injection from each vial is always done in the office, and the patient is given that particular vial to take home with a schedule to slowly ramp up the dosage. In 6 weeks, the patient returns to the office and is given his next vial, from which he receives the first injection again. Actually, the patient does his own injection to demonstrate competence in drawing up the serum and administering the shot. We usually start a new vial with a dose of 0.06 milliliters, but can adjust the dosage if the patient cannot return in exactly 6 weeks due to vacation, etc. The patient then gives a next dose of 0.06 at home, with an increase of 0.03 milliliters each subsequent shot until he reaches 0.039 milliliters in 6 weeks. To maximize safety, we never want the patient to inject more than a 50% increase over their last injection. If there's a delay in getting back to the office at 6 weeks, the patient is instructed to stay on the 0.039 milliliter dose. There should be enough extra serum to stay on 0.039 for several more doses. This form summarizes the typical office visit when a patient returns for each in-office injection. It includes all of the pertinent data about the allergy shot given, as well as documents a review of the patient education. At each visit, the allergy nurse will review and document the safety instructions, including how and when to use their EpiPen. This form is designed in a typical SOAP format, with a space for the physician to document his exam. Some physicians are too busy and don't want to see each allergy patient for each immunotherapy visit, so they have the allergy nurse fill out this form and charge a level 1 visit. I like to talk with the patient at each visit to see how immunotherapy is going and document an exam, justifying a level 2 or 3 office visit. The next several slides will show some of the forms that we have the patient review and sign at each visit to reinforce their training and hopefully prevent complications. This is our immunotherapy compliance agreement. We go over it line by line with the patient so there's no misunderstandings and the patient initials each line. This should help reduce any liability to the treating physician. This is our waiver and consent form. It is extremely important that the patient understand the potential risks, and we spend a great deal of time educating them to decrease the liability for our doctors. It is also important that patients are chosen appropriately. For example, if a patient has been habitually non-compliant or they are mentally disabled, they're probably not good candidates for this program. This is our patient safety and instruction form, which gives the patient further instructions such as not to exercise before injections, take an antihistamine on injection days, and to have another friend or family member present when giving injections in case the patient has a reaction. Asthmatics are advised to check a peak flow prior to all injections and call the office if less than 70 to 80% of their personal best. This form also reviews instructions on giving injections and disposing of needles. It seems like there is a lot of paperwork for the patients to fill out, but for the patient's safety and for your liability, it's all very important. Here are our adjustment protocols. We use a point system to determine how to adjust the dosage if the patient has a reaction or misses a dose. Occasionally, a patient leaves his vial unrefrigerated or loses a vial. Sometimes they don't do their injection for a few weeks for various reasons. The dosage must be decreased to limit the risk of a severe reaction. The patients are advised to call the office for an appointment to see the allergy nurse specialist in any of these circumstances for a dose adjustment. For example, if a patient has not received an injection for 3 weeks, they are instructed to re-inject the second to last non-reactive dosage twice, then continue. If a patient experiences a systemic reaction, our nurses complete this incident report. All of these reports are reviewed personally by me as our medical director to ascertain if there was any deviation from our safety protocols or if patient or provider error could have been avoided. Sometimes reactions are unavoidable and the dosing schedule has to be customized for that particular patient. We have an excellent safety profile and we strive to have the lowest possible reaction rate. Reviews of the allergy literature show a systemic reaction rate of 0.6%. To date, we have supervised over 200,000 injections and have had only 4 systemic reactions with no fatalities. Home-based immunotherapy. Now we're getting to the good stuff. This is the most exciting part of Allergy 123. You can certainly perform all of the allergy injections in your office as the allergists do, but home-based therapy offers the patient huge cost savings and convenience. Rather than taking time off of work once or twice a week to go to the allergist's office for their shot, the patient, with proper education of course, can do their own shots at home. This can save the patient thousands of dollars in copays and reduce the huge cost burden on the healthcare system in general. Obviously, compliance and thus efficacy is much better. This approach to immunotherapy has previously not been endorsed by the allergy community, but some allergists are getting on board now that the safety has been so well established. The ENTs are leading the field in this type of treatment, and their complication rate is much less, as we saw earlier in Module 2. If anyone ever accuses you of practicing reckless medicine by allowing your patients to do their own allergy shots at home, remind them that doctors prescribe insulin for home injection for type 1 diabetics every day. Which do you think is safer? Here's a couple of really interesting studies I found. A study of more than 1,700 allergists showed that 57% of them admitted giving a shot to the wrong patient in their office, and 74% admitted to giving an incorrect dosage. These errors led to 59 ER visits and 1 death over a 5-year period. The chance of giving the wrong extract to a patient on home-based immunotherapy is 0 unless multiple family members are receiving immunotherapy. And the wrong dose is also much less likely than a nurse giving shots to hundreds of different patients. Another study of 42,000 patients in numerous allergy offices showed that 11% of the patients for whom the entire course of immunotherapy was prepared and paid for did not even show up for their first injection. Additionally, 13% quit the program within their first 3 injections. Let's do the math on these 2 groups of patients. That's about $100 million. What a waste. The discontinuation rate in the Allergy 123 program is less than 10%. For patients who absolutely refuse to do injections or cannot do injections, sublingual immunotherapy is a good alternative. The same extract can be used, but it's placed under the tongue rather than injected. It's important to inform patients that SLIT, or sublingual immunotherapy, is not yet FDA approved, will cost more because it requires a larger quantity of extract, and requires a longer course of treatment. SLIT is actually a safer alternative to subcutaneous immunotherapy, as there are fewer systemic reactions and no deaths have been reported. But it is not as effective as subcutaneous, 60% reduction in symptoms versus about 85%. Local reactions are more common but mild. Dosing for SLIT is similar to SCIT, except doses are given 6 days per week with incremental increases twice a week. Here's our typical sublingual dosing schedule. It's very similar to SCIT, but the dosing schedule is 6 days per week with incremental increases twice a week. We usually recommend a 3 to 4 year course of treatment for SLIT. Because we are new and because some allergists are threatened by this approach, we have probably the most rigid safety protocols in the business. We use the highest quality allergens not only for testing but also for treatment. We use a slower build-up phase which decreases the chance of severe reaction, and we use more frequent dosing maintenance regimen, which increases the efficacy of treatment and decreases the treatment time. We also use fewer antigens, which not only decreases the risk, but also increases the effectiveness of immunotherapy. We recommend treating most patients for 2 years rather than a typical 3 to 5. We don't treat food and insect venom allergies or severe asthmatics, all of whom are much more dangerous to treat. Our goal is to treat the milder allergy patient because immunotherapy is actually more effective in this group, and of course the risks are lower. The most important difference is that we partner with the primary care physicians, so you can offer an additional procedure that will increase your patient's satisfaction because it's more convenient and much less expensive, and provide a huge revenue source for your practice. Our expert allergy staff provides all the necessary equipment and patient training at no cost to the practice. We also perform a benefit check with the patient's insurance company so the patient knows exactly how much out-of-pocket expense they will incur. Coding and billing for allergy services is actually quite a simple process. An allergy skin test is coded as 95004, but be sure that you bill for 60 units. That's 58 antigens plus 2 controls. Preparation of an entire year of immunotherapy serum is done at once and is coded as 95165. You need to bill for 100 units for the ramp-up phase on the first mixture and 100 units for a 6-month maintenance regimen for the second mix 1 week later. It's important to understand that all of the antigens are prepared at once because serial dilutions are made from the original concentrate. Extra serum extract is always prepared in case the patient loses a vial, forgets to refrigerate it, or requires a dosage adjustment. At Allergy 123, we understand how primary care has always gotten the short end of the reimbursement stick, and in order to survive, we have to look at other sources of income. The financial impact of partnering with Allergy 123 is incredible. There's no other procedure done in the primary physician office that even comes close to the reimbursement you can receive by doing allergy testing and immunotherapy. The average reimbursement is about $400 per test and $2,800 per 12-month course of immunotherapy. This translates to over $150,000 per year net for an average physician doing 3 tests per week, with half the patients electing to go through with immunotherapy. Remember that 20 to 30% of your patients have allergies, so a patient with an average patient load of 3,000 patients should yield 600 to 900 potential candidates. It's important for you to remember that there are no upfront costs to the practice when you partner with Allergy 123. Here are some of the frequently asked questions I've come across. What if a patient can't make it in for immunotherapy visit in exactly 6 weeks? Well, they can stay on their last dose of 0.039 milliliters for as long as they have enough serum, or they can come in a little early, say after the 0.30 dose, and the initial dose from the new vial can be adjusted. Remember, do not inject more than a 50% increase with each dose. What do we tell patients who live alone and don't have an injection partner? I would suggest that they ask a neighbor to do the shots or do the shots at work with a coworker. What if a patient leaves their vial out at room temperature overnight? Even though we tell patients to keep their serum refrigerated at all times, it does not lose significant potency if left at room temp for 24 hours or less. The maintenance vial is actually stable for at least 2 days. If a vial is exposed to freezing or high temps, it needs to be replaced. What if a patient's going on vacation for a week? Well, they can suspend their injections for a week and resume according to the adjustment protocols. Does a patient need to withdraw from immunotherapy if he has a significant systemic reaction or a persistent large local reaction? Well, that depends on many factors. I usually restart at a lower dosage and ramp up more slowly. The doctor can certainly call and consult with our medical director for help in making this decision. What if a patient is moving out of state? We may have a doctor participating in the Allergy 123 program in their new state. We're currently in 8 or 9 states and hope to be in most states in the U.S. in the next year or 2. Suppose repeat allergy testing shows complete resolution of treated antigens. Can we do the second year with different antigens? Yes, you can, but they're unlikely to get permanent relief from the original antigens if they don't complete a second year. I hope you're not too exhausted by now. I know I've covered a lot of information in a short period of time with these 3 modules, but I know if you take the time to really understand these principles, you'll have no problem convincing anybody that you are truly a specialist in allergy treatment. There's a shortage of allergists in this country, and the incidence of allergic diseases is still increasing. With the Affordable Care Act, I think we'll see more and more incentives for primary care docs to do procedures previously relegated to specialists. Allergy testing and immunotherapy is well within the scope of practice for any primary care physician, and it's a shame that more PCPs don't offer this valuable service to their patients. You don't have to be a board-certified immunologist to perform these simple tests and procedures safely, because we've done most of the legwork for you. After you've gone through our entire training program, you should be quite comfortable treating these patients, and I think you and your patients will be surprised at how effective immunotherapy is, permanently. I would also encourage you to review this information again prior to starting your allergy clinic, and maybe again after you've treated several patients. It's been a pleasure sharing this information with you, and I thank you for choosing to partner with Allergy 123.